In this episode, we're tackling a question that sits under every AI conversation happening in healthcare boardrooms right now. Where should AI strategy actually begin? Every hospital has an AI list nowadays, use cases, pilots, vendor demos, governance committees, and roadmaps. And across my work in healthcare operations, I've repeatedly observed the same thing. Most of that activity has no strategic center. Which challenge deserves priority? Where scarce capacity should be concentrated and what should be stocked? Those decisions have not been made. So here's why that matters and why it matters specifically for AI. A healthcare system can survive a mediocre IT project, perhaps. It can absorb a failed software rollout, a governance committee that never quite finds its rhythm, a training program that reaches half the intended audience. The organization keeps functioning, but AI is different in three ways that raise the stakes on strategic discipline. First, AI investments consume the scarcest resource that the organization has: clinical attention, integration capacity, data engineering, executive sponsorship, governance bandwidth, and risk management. You cannot run 20 AI projects the same way you can run 20 small IT projects because AI touches the workflow, it touches the decision, and it touches accountability at the same time. Second, AI changes the environment around you whether you invest or not. Competitors, vendors, employers, and patients are already behaving differently because of it. Inaction is a decision. And third, AI creates risk in categories that boards and regulators are just now learning to ask about. So bias, decision transparency. Every unmanaged AI initiative is a governance exposure that an organization did not knowingly accept. So the cost of activity without strategy is higher for AI than for almost any other technology we've adopted. And the healthcare organizations that will produce durable value from AI over the next 5 years will not be those with the most pilots. They'll be the ones with concentrated capacity on the challenge that mattered most. Connected AI to the work where it changes the response and built the organization system around it that turns a model into a decision and a decision into accountable action. So that's what this episode is about. Not a technology framework, a strategy framework. And I'm going to make it concrete by taking one real health enterprise challenge and walking it through the full sequence so you can see how each decision shapes the ones that come after it. There's a connected sequence any organization has to move through if AI is to produce enterprise value. You have to, one, read the environment, define the enterprise challenge, identify the critical obstacle, find the critical operating flow, determine the role of AI, concentrate your portfolio. You can't be scattered all over the place. Design the full organizational response, assess readiness, implement and measure through to healthcare value and the next decision. When one of those links is weak, the initiative may still produce an output, but it is less likely to create sustained capability. And most AI activity I see in healthcare has 3 or 4 weak links. Now, let's say a regional health system is losing patients and referrals to competitors and new entrants. Volumes in several service lines have been drifting downwards for 2 years. A national retail health player has opened 3 urgent care sites inside the system's primary market. An ambulatory surgery center backed by a private equity group is capturing the higher margin orthopedic and gastro cases. 2 large employer groups have carved out direct contracts with a competing system for musculoskeletal care. Independent specialists who used to refer everything in are now sending selectively. Imaging here, procedures there. So now you have your CFO watching the payer mix deteriorate as commercial volumes fall faster than public volume. The CEO is under pressure from the board because market share is a leading indicator of everything else. So this is your enterprise challenge. Now let's watch how we apply a discipline sequence to manage this. So before we even define the challenge properly, we have to read the environment. Strategic sensing is the discipline of deciding which external changes alter the organization's assumptions. So in this scenario, sensing tells us that the environment has shifted in several ways at once. New entrants are now unbundling profitable services. Employers are becoming active purchasers rather than passive payers. Patients are behaving more like consumers and choosing convenience over loyalty. Digital front doors are becoming the first touchpoint for care, and referring physicians are making decisions based on ease of scheduling and communication as much as clinical quality. AI is part of this sensing picture too, because your retail entrants are using AI-driven triage and scheduling to convert digital entries into booked visits faster than most incumbent systems can. Sensing reframes the challenge. So it becomes not just about losing volume, it's about a healthcare system whose access model was built for an era when patients waited for their turn, and whose competitors have built access models for an era when patients do not. So the sensing allows you to better define your challenge. And you have various tools for doing your organization or environmental sensing. You have your classic strategy tools and so forth. Now, define the enterprise challenge within that context. So this draws on Richard Romuald's challenge-based view of strategy: diagnosis, identification of the addressable part, and coherent action. The C-suite might state it this way: the health system is losing preferred market position because its access, convenience, and referral experience no longer match what patients, employers, and referring physicians expect, and that gap is widening. That's a diagnosis. It names the terrain. Compare that to an ambition like become the digital health leader in the region. What does that mean? It's a destination, but it does not tell you what must be overcome. All right. So step 2 then is finding that critical obstacle. The largest and most visible problem is not always the right point of intervention. So the visible problem is falling volume, but the limiting obstacle is what is producing the falling volume. And here we have to be honest, because there are several candidates. Is it that new patients cannot get an appointment quickly enough and go elsewhere? Is it that referring physicians find it harder to send patients into the system than to send them elsewhere? Is it that the digital front door, the website, the patient portal, the call center creates friction that competitors have already engineered away? Is it that pricing transparency and out-of-pocket cost is now a purchase criterion that the system has never addressed? Is it that service lines have quality or experience gaps that show up in employer purchasing decisions? Each of these is consequential. Each of these requires a different response. It's not just let's implement AI. Some require AI, some don't. And the organization can only concentrate on one or two at a time as the critical obstacle. So let's say the diagnosis lands here, the referral and new patient experience or access experience, from the first digital or phone contact through to the booked, confirmed appointment to the right clinician, is where the system is losing the most winnable ground. Employers, patients, and referring physicians all touch the same experience. Fix it, and the other obstacles become easier to work on. Leave it broken, and every other investment is compensating for a leaking front door. So you notice what happened there. The enterprise challenge, losing market position, did not translate directly into an AI strategy. It translated into an obstacle. The front door experience is losing us winnable patients and referrals. Now, the obstacle can be worked on. So, step 3 is to find the critical operating flow. The obstacle has to live inside a real workflow or nothing will change. The critical operating flow here is the referral and inquiry to confirmed appointment pathway. That flow starts when a patient searches, calls, or is referred, and ends when they show up for a visit, with the right clinician at a time they didn't have to wait months for. It runs through the call center, the website, the patient portal, the referral inbox, scheduling teams, clinic templates, insurance verification, and communication with the patient and the referring physician. So my experience is that frontline staff know this flow better than executives do. Your schedulers know which specialties nobody can get into. Call center agents know which requests they cannot route without escalation. Referral coordinators know which physician offices give up and send patients elsewhere. The declared process, the one on the org chart, and the real process are always different. Any strategic response that skips studying the real flow would optimize the wrong thing. Digitizing a broken referral pathway just makes your failures faster. Right? So let's look at step 4. Determine how AI changes the response. Now we're getting down to it. Here's where the executive team has to resist a temptation. The temptation is to say, we need an AI-powered digital front door, and then start evaluating vendors. That's choosing the tool before the diagnosis is complete. AI plays 4 distinct roles here, and only 1 or 2 can apply. As a direct intervention, AI can classify inbound referrals by specialty and urgency, extract clinical information from referral documents, match the patients to the right clinician's template, and generate proactive scheduling suggestions. That is genuinely useful for this flow. It can also be an intelligence capability. AI can forecast demand by specialty and geography, detect which referring physicians are shifting behavior, and identify which patient segments are being lost at which points in the funnel. That is where the C-suite finds out what is actually happening. Or it can be an external strategic force. AI is already changing the environment because competitors are using it in exactly the ways I just described. The gap is widening every quarter that the incumbent does not respond. And as an unnecessary complication, this matters, right? Parts of this problem do not need AI at all. If the call center is understaffed at the times patients call, no AI fixes that. If clinic templates reserve slots for a referral pattern that no longer exists, that's a scheduling decision. If insurance verification takes 3 days because it's a manual handoff between 2 teams, that's a process design problem. AI belongs where it improves power, speed, quality, handles ambiguity at scale, or the economics of the response. Everything else can be overhead. So once the role of AI is clear, the next question is the portfolio. AI investments compete for scarce organizational capacity. It's not just money. There's clinical attention, integration resources, data engineering, training, governance review, leadership time, implementation support. In this scenario, the portfolio may look like this. The direct challenge investment is the intelligent referral triage and scheduling for 2 service lines losing the most share. The enabling investments are cleaning up the referral data, integrating the call center and EHR, and rebuilding scheduling templates. The option investments are small experiments, testing an AI-assisted patient on the website for 1 service line, testing predictive no-show interventions in 1 clinic. And then you have mandatory investments like safety, privacy, consent protocols that any patient-facing AI needs. And then there's a stop list, the enterprise data lake project that was going to take 18 months and doesn't serve this challenge. All right? The ambient documentation pilot that is not on the critical path. An organization that funds everything has not made a strategy, it has just postponed a decision. And then step 7 is to design the organization, the full organization response. A model, a tool, and a deployed system are 3 different things. For the referral triage AI to actually change the front door experience, the deployed system has to include the software, the referral and scheduling data feeding it, the schedulers and referral coordinators using it as an output, the workflow they follow, the decisions they make when AI flags an exception, the monitoring of whether patients are actually getting appointments faster, The governance around how the AI suggestion can be overridden, and the change control for when clinic templates or specialty definitions shift. Ownership must include authority. The person accountable for the referral experience has to be able to change clinic templates, redeploy call center staff, override scheduling rules, and escalate when a specific service line's capacity is the constraint. Responsibility without decision rights creates stalled implementation. An accountable executive gets held to a metric that they cannot move. So governance should not sit outside the strategy as a final. It should define the boundaries, evidence requirements, and stop conditions that let the organization learn without exposing patients to unmanaged risk. But one pattern that I have seen repeatedly is that list without workflow pattern. The AI produces a list of referrals ranked by urgency or a list of patients at risk of no-show. Staff can see the list, but the decision rules, ownership, escalation routes, and follow-up cadence are missing. The information exists, the work doesn't move. In this scenario, the referral triage AI is worth nothing if the referral coordinator team does not have an updated protocol for what to do if a high priority referral cannot be slotted within the target window. Strategic intelligence creates value when it changes a decision, and the decision creates value when it produces accountable action. Readiness determines what is genuinely possible before implementation begins. So my experience includes digital health readiness assessments where the apparent technology rested on an outdated infrastructure, poor access controls, low digital capabilities, siloed data, and limited interoperability. In this scenario, the referral triage AI depends on referral data that currently lives in 3 systems if you're lucky. A call center platform that doesn't integrate with the EHR, scheduling templates maintained by service line administrators who've never harmonized their rules. All right. Registration that lives between 2 separate divisions of the organization at different times. Readiness is not a later problem. It is what determines whether the response is available to the organization at all, and it dictates sequencing. Some of the enabling investments may have to precede the direct challenge investments by several months. So you may have to wait until your organization is ready. Though the critical obstacles that you're fixing to address the next one and make it easier to progress may start way earlier in the chain or in the maturity level than you'd want, but is to build up to what you want. Implementation is where AI investments will quietly die. A system can be built, delivered, and formally accepted while failing to become a part of the normal work. Staff revert to old processes, dashboards go inactive. In this scenario, that looks like referral coordinators using the AI ranking for 2 weeks and then falling back to their old spreadsheets because the AI's output requires an extra click or because it flagged something they disagreed with, and nobody resolved the disagreement. Adoption requires phased rollout, coaching, daily or weekly review routines, manager reinforcement, and follow-up after the project team leaves. Measurement will then follow the full path. Technical performance. Is the triage AI accurate? Safety. Are urgent referrals being correctly identified and are overrides tracked? Adoption. Are your referral coordinators actually using the output? Operating performance. Is the time to appointment falling for targeted service lines? Healthcare value. Is the system recovering market share? Is referring physician satisfaction improving? Is payer mix stabilizing? Model accuracy is intermediate evidence. The final question is whether the health system's competitive position is measurably better than it was before the investment. Now, let's bring it back. The enterprise challenge was the market position. The obstacle was the front door experience. The flow was the referral to confirmed appointment. The AI role was direct intervention and intelligence, not everywhere, not the whole answer. The portfolio concentrated capacity on one flow, deferred distractions, and named the enabling work. The organizational response gave one accountable owner authority to move templates, staffing, and process. Readiness set the sequence, implementation made adoption a management job, not a launch event. And measurement tracked all the way through to whether the system was winning back share. That is what disciplined AI strategy looks like at the enterprise level. It's not a list of tools, it's a chain of decisions where each link constrains the next. So, one thing to do in your next executive team meeting or strategy planning, name that enterprise challenge your health system is actually facing, the one your board will recognize. Then ask whether your current AI portfolio addresses the obstacle inside that challenge or a different one entirely. If the answer is a different one, you know exactly what to fix first. Healthcare AI should be judged by the organization's improved ability to address important healthcare challenges, not by the number of tools deployed, pilots completed, models approved. That's the measure that matters. Everything else is activity. So thanks for listening to Leading Healthcare AI. If this episode shifted how you're thinking about your organization's AI strategy, share it with somebody on your leadership team who needs to hear it, and I'll see you in the next episode.